It's a pleasure for me to be part of this session on genetic analysis in various views in coagulation disorders. I was asked to speak about what is the additional value of genotyping to establish a correct diagnosis. These are my conflicts of interest. Genetic diagnosis has been a long journey, and I actually started my MD thesis on RFP analysis in hemophilia A with the purpose of carrier diagnosing in 1984, just the year when the factor VIII gene was discovered. And during all this time, a lot of new mutation mechanisms were found. Every few years there was a further development. Very important milestone was the intron 22 inversion, the most frequent mutation in hemophilia A. Other more rare mutation types, now we are getting, and the next presentations will address this, in the era of next generation sequencing and more genome-driven analysis. In the very beginning, genetic analysis was almost completely driven by the purpose of carrier diagnosing and family diagnosis. In the beginning of the 90s, the motivation for genetic analysis moved to getting more information on the patient, and especially on the inhibitor formation, but also other clinical features of the patient. So the motivation from the genetic diagnosis moved from initially carrier and family diagnosis to getting more information on the patients themselves. Nowadays, genetic diagnosis has become a routine laboratory test, at least where we have the resources to do such testing. It has become much less costly. Various technologies are available, the classical Sanger sequencing, but also next generation sequencing or third generation sequencing. So genetic test has the potential, and in many areas have become already a routine test. The genetic analysis is providing information to the phenotype of the disease of the patient, like a laboratory value, and sometimes this information is very helpful. We have learned from mutation analysis in hemophilia A that the type of the genetic defect is responsible for the risk of inhibitor formation, and this has very much driven the mutation analysis in hemophilia A patients. So it's widely accepted that null mutations, severe rearrangements in the factor VIII gene with no secretion of a functional protein, have a high risk of inhibitor formation, and non-null mutation like missense mutations that have an endogenous synthesis and a secretion of the factor VIII protein have a low risk of inhibitor formation. Now I would like to address two questions. The first question is, why does the same mutation cause inhibitor in some patients and in others not? So we have a patient with an intron 22 inversion, and when he is receiving factor VIII, then the immune response towards factor VIII is processed through a cascade of immune response genes, and at the end of this cascade, we have either tolerance to factor VIII, which is an active process, for example, caused by generation of factor VIII specific regulatory T cells, or we have intolerance to factor VIII, which means antibodies towards factor VIII by factor VIII specific T cell activation. These immune response genes, the setting is individual for each patient due to polymorphisms, due to variations in those genes, and a number of these genes have been already addressed with the risk of inhibitor formation. Here we have a cartoon of the correlation of the inhibitor prevalence to the type of the mutation. So a multi-domain deletion has a risk of almost 90%. We have another group of large deletions, nonsense mutations, intron 22 inversions that have a risk of 20 to 40%, and then a group of other mutations like specific small deletions or missense mutations that have a very low risk for inhibitor formation. This is widely accepted and has been addressed in many reviews. There's a huge review on several thousands of patients from Samantha Howe summarizing these results in more detail. But one of the questions is, why do different null mutations cause different risk of inhibitor formation? Why the inhibitor formation is different in an intron 22 inversion, in a nonsense mutation, in a large deletion? They all represent severe molecular defects. They all have no endogenous factor VIII activity at all. So why is inhibitor risk so different? And I would like to show some results that were presented yesterday by Heike Singer from our group. She looked especially for nonsense mutations and intron 22 inversions. So here we have the factor VIII gene with all the exons. In gray, the number of cases, and in red, the proportion of inhibitors in those patients. For the heavy chain, these are nonsense mutations, all stop mutations, and for the light chain. And on the first view, you can see that in the light chain, we have higher red bars than in the heavy chain, so a higher proportion of inhibitors. If you go in more detail, that is shown here, especially the A3 domain seems to have a high risk of inhibitors of about 60%. If you then go in more detail, exon 18 is coding for part of the A3 domain, the risk is about 70%, and if you then go for specific mutations like these two mutations, the risk of inhibitor formation for a stop mutation can be up to 80%. Why do we have a higher risk for inhibitor antibodies when the nonsense mutation is located in the A3 domain, for example, compared to when it is located in the A1 domain, where the inhibitor formation is almost absent? So Heike Singer, what she did is she took blood from patients and generated immune pluripotent stem cells from this blood, which then was transdifferentiated to a generic vascular endothelial cell. The benefits of this patient-specific cell system is that you have all the gene information of the patient, including all intronic sequences. You could detect specific mechanisms inside the cell, like nonsense-mediated mRNA decay, and you could do trafficking studies of the various parts of the factor VIII protein. And here the results are summarized just for one domain. It's a A2 domain of the factor VIII protein. I will just refer to the first column of pictures. In green, that is a factor VIII protein that is synthesized endogenous inside the cells. And this is a wild type, a normal cell. This is a patient with an intron 22 inversion, and you can see huge amounts of factor VIII are made, but the localization of this factor VIII is way, way different compared to the wild type. If you go further to the nonsense mutation, you see it is less factor VIII. The trafficking, again, looks different from the intron 22 inversion. So Heike Singer tracked the various domains of the factor VIII protein intracellularly and presented yesterday the information and the data. So I would just summarize her presentation. Null mutation in hemophilia A means that there is no secreted factor VIII protein. It does not mean that there is no endogenous protein. As you just have seen, she found endogenous factor VIII protein in very, very significant amounts intracellularly. In intron 22 inversions, more than in nonsense mutations, and she's now also studying other mutation types. So these mutations differ with respect to the intracellular factor VIII content, which may contribute to the immune tolerance. The intracellular protein content is less in large multi-domain deletions, which a little higher in large deletions, a little higher in stop mutations, and almost completely present in intron 22 inversions. And what we observe in the epidemiologic inhibitor studies is that we have different risk for these mutation types of 80%, 40%, and 20%. So this correlates very well to the amount of intracellular present protein. And this information we hope to be used in the future for individualizing treatment strategies when we identify a high-risk mutation, then to stratify the treatment during the first 20 to 50 exposure days, to avoid peak treatment moments, avoid elective surgery, avoid danger signals, start with a low-dose early prophylaxis. Some studies have started this. So far, they were not really successful in preventing inhibitor formation, but we hope that in the future we will find more markers to follow and to be more powerful in using this information in influencing the risk of inhibitor formation. Another group where we getting information on the type of the mutation for the course of the disease in the inhibitor patient is the bleeding phenotype. We have the type of the mutation that is very important, but we have also co-inherited genetic variables like prothrombotic mutations. The von Willebrand level may be decisive. And I would like to give a few examples from these data. This is a publication from Elena Sant'Agostini. She looked on parameter in mild bleeders that were 22 patients compared to all controls that were 50 patients. They all had a laboratory phenotype of severe hemophilia. And she found that in the mild bleeders, the median age at the first joint bleed was 84 months, so 7 years, compared to about 2 years in the controls. The median number of bleeds per year were 0 in the mild bleeders compared to 20 in the controls. The joint score was much higher in the controls. And the only difference she found was that the proportion of null mutation in the cohorts. In the mild bleeders, the proportion of null mutation was only 10%, while it was 60% in the controls. So the factor VIII mutation has a strong influence on understanding the bleeding phenotype. These are data from the PETNET study published from Manuel Cacao. He had a group 1 with null mutations, a group 2 with non-null mutations, and he found that in the null mutations, the median age at diagnosis was earlier, the median age at the first bleed was earlier, the median age at the first joint bleed was earlier, and the median age at prophylaxis start was earlier. There was not huge differences, but they were statistically significant. Here are some more data from our center. So if you have a classical severe molecular defect, like this group B, stop mutation, intron 22 inversion, you have a factor VIII activity below 1%. And if you do a thromboelastogram, the thromboelastogram starts clotting after 2 to 3 hours, so about 150 minutes. We looked more specifically at a group of small deletions, which in principle is also a severe molecular defect because a small deletion leads to a frame shift, to a stop codon, and a severe phenotype. Laboratory, these patients also showed a severe phenotype. For the clotting start in the thromboelastogram, we observed just 30 minutes in these patients. So they had a very significant difference in the thromboelastogram and also in the bleeding phenotype. The reasons are two series of adenines in the B domain, shown here in red, which contribute to 25% of all small deletions in hemophilia A. And I will go a little bit more in detail to the second adenine series. Here you have a T, and if the T is deleted, there are another 2 adenines, and you have a sequence of 10 adenines. And there was one group about 20 years ago. They looked about the transcriptions of these adenines. This is a patient without the mutation, and this is a patient with the mutation causing then 10 of these adenine nucleotides. The majority of transcripts showed the right size with 10 adenines, but there were also several mistakes during the replication process, and a small proportion shows 7 adenine subscribes, and this is restoring the reading frame. All 3 nucleotides are coding for 1 amino acid, so this is restoring the reading frame. Because this mutation is in the B domain, that is non-functional for factor VIII, it doesn't matter if there is 1 amino acid less. So this is a reason why these patients show a low bleeding phenotype, because they have some endogenous factor VIII activity. It's somehow a self-correction during the replication process for this type of mutation. Another important genotype-phenotype correlation are assay discrepancies. We have learned that in mild hemophilia, about 30 to 50% are showing assay discrepancies between the 1 stage and the chromogenic assay, depending where you're setting the cutoff. If you are setting the cutoff by the multiplicator of 2, then it's about 1/3 of the patients. Here are a number of mutations where the 1-stage assay is significantly higher than the chromogenic assay. The ratio is between 2 and 4 times higher factor VIII activity with the 1-stage assay than the chromogenic assay. Sometimes this affects the diagnosis. With the 1-stage assay, the first patient would have a moderate severe hemophilia, while with the chromogenic assay, it would be a severe phenotype. The second last patient with the 1-stage assay, he would have a mild hemophilia. With a chromogenic assay, a moderate severe hemophilia. The reasons are that these mutations, the red and the green spots, they are located between the various domains at the interfaces of the domains of the factor VIII protein, and the chromogenic assay is especially sensitive for this promotion of factor VIII dissociation. We have also mutations where the factor VIII 1-stage assay activity is much, much lower than the chromogenic factor VIII activity. This is shown for this series of mutation. In many of them, you even can't diagnose hemophilia at all with the chromogenic assay. The activities are completely normal, and the ratio is about 5 times higher with the chromogenic assay than with the 1-stage assay. The reason is the mutations are scattered, but most of them are close to thrombin cleavage sites. And this is affecting the affinity of thrombin to factor VIII, the activation of factor VIII by thrombin, and the 1-stage assay is much more sensitive to this than the chromogenic assay. We have other coagulation factor deficiencies that are also addressed by genetic analysis, rare bleeding disorders. Here we have a number of factor VIII of hemophilia A patients with identified mutations of factor VIII gene that have additional mutation in other genes. Here in the fibrinogen, which may not affect the phenotype very significant because fibrinogen levels are still very good. But for this patient here, we have a factor VII activity of 15%, which may affect the clinical phenotype. or in these two patients on the right side, where we have a combined hemophilia A and von Willebrand phenotype, which also then has consequences for the treatment because these patients need to be treated with a von Willebrand containing factor VIII concentrate. So these data now are coming more and more apparent with the next generation sequence technologies where we're looking at 100 genes at the same time and are able to identify combined clotting factor deficiencies. Here's another example how a mutation could help for treatment decisions. This is an antithrombin gene, and there's a heparin binding site, and a series of mutations is affecting this heparin binding sites. Those patients have a lower response to heparin when complications are like thrombosis required anticoagulation therapy. So if we have the genetic defect, we understand why these patients do not respond to heparin and need other coagulation drugs. Here's a case report of a von Willebrand type 3 patient. It's two patients, two sisters, 23 and 26 years of age with a type 3 von Willebrand disease. They have both a homozygous large deletion of exon 6. The parents are consanguineous. However, the older sister is a frequent bleeder and requires a regular prophylactic treatment, while the younger sister is not bleeding at all and is treated on demand. Further analysis revealed, the two sisters are on the right side, that the younger one contains additionally a mutation in the antithrombin gene. So she has a mild antithrombin deficiency, and this mild antithrombin deficiency, we know it's prothrombotic risk factors. We all have heard during this Congress the power of fitusiran as an endogenous thrombin downregulator for improving the coagulation. So this younger sister is containing a antithrombin mutation that is balancing the bleeding risk. Another very exciting family was this family that was coming in our outpatient clinic in 1997. It was a pregnant woman of Lebanese origin. She was pregnant in the 30th week. She was referred by a gynecologist to us because he has diagnosed a hydrocephalus and intracranial bleed in the male fetus. She had 7 living children, 2 further died at birth. 1 living daughter experienced an intracranial bleed. So there was a bleeding anamnesis. And when we looked in more detail, we identified a deficiency of all vitamin K-dependent factors in this family. Then after the work of several years, the gene was identified. It was a vitamin K gene of the vitamin K pathway, and a mutation was identified in all patients that show the phenotype. It was a homozygous mutation. This mutation led also to the discovery of this gene that was the protein that is responsible for all the recycling of vitamin K within the vitamin K cycle. It is a reason for this new subtype of vitamin K-dependent clotting factor deficiencies, but it's also the gene that is responsible for warfarin resistant, and this gene has also gained a lot of attention because it is modifying the warfarin dose response. This is a publication that is using next generation sequencing with a panel of 63 genes. If the etiology is suspected, so if a good phenotype is there, the rate of successful identification of the gene defect is very high. It's about 90%. If there is no suspected etiology, just more general bleeding disorder or thrombosis disorder or platelet disorder, then the chance of identifying the gene defect is quite low. Nevertheless, we will hear in the next two presentations that next generation sequencing will be the future for diagnosis in bleeding disorders and thrombosis disorders. So in summary, genotyping has an additional value. It's establishing the correct diagnosis. It helps understanding the patient's clinical presentation of the disease, the phenotype. It's helpful for adjusting treatment strategies. It's allowing family counseling, and as I have shown you, it may lead to exciting science. Thank you very much for your attention. This is our group on the left side. Heike Singer has presented some results yesterday. Anna Pavlova is managing our diagnostic lab, and the others are PI on various projects. Thank you.